Testing. Okay. Could you please tell me a little bit about your professional background and why you became a psychiatrist?
I'm Heidi Sobel. Let's see, my background is a little bit, I don't know how traditional it is or not, but I have a background in anthropology and biochemistry. I've studied homeopathy and some Reiki, and I went to medical school, so I have my MD, and I did residency in psychiatry. And what led me to become a psychiatrist? I think it was probably through my anthropology work. I was going to be a family doc, family medicine person. But when I was doing a study on how women made a decision to either breastfeed or bottle feed their babies in Peru in the shanty towns. And I was interviewing people and doing ethnographic interviews. And what I realized is that I really liked sitting with people and hearing their stories. And somehow I thought that was what psychiatry was.
Has that not been the case?
I don't know. So I thought, that would probably be more up my alley. And also, I decided I really didn't like the hospitals. I didn't like wearing white coat. I didn't like doing procedures on people. So I thought, psychiatry might be, up my alley. Also, I thought I would be working with kids. But by the time I had to make that decision, I realized I really didn't want to be medicating kids. And so I just, stopped after residency in adult psychiatry.
Okay. How long have you been practicing for?
So when I started residency, I guess that's when you would say the start of practice. So it would have been in 1990, that summer. Because residency is considered, the start of practice. So 1990 to now is what? 2025?
So 35 years.
Okay. That's it then.
That's a long time.
That is a long time.
And why did you decide to practice here?
Well, I did my residency here. So when I first got out of residency, it was just I like New Mexico. I wanted to stay in New Mexico. So I got a job here. At some point, I moved back east, where I'm from Connecticut, and I worked in Maine for a while. The reason why I moved out of New Mexico is because things were getting to be more managed care. And a lot of the agencies were wanting to hire psychiatric nurses instead of psychiatrists because I think they could pay them less. And all the medications were in formularies, and insurance companies weren't. It was difficult to practice here, and so I moved back east. I worked in the community center there for 7 years or so, and then when I got married, we moved back to New Mexico because my husband could get a job here.
Okay.
Yeah.
Kind of come full circle.
Yeah.
Okay, what is your specialty in?
Well, I'm a general psychiatrist. I see adults. I don't really have, a specialty.
Okay, and where or what settings have you worked in and do you work in now?
Okay. I have always worked in community mental health, in public health kinds of nonprofit clinics. So I've never done, a private practice per se, and I've not worked for profit organizations.
And where do you work now?
Right now I work at First Nations Community, what do they call it? Health Source. We used to call it First Nations Community Health, but they added on the source. Yeah.
What type of patients do you see there?
Well, First Nations, when it was originally, I think, we have a clinic, we have a number of clinics in town and also across the state, but I think its first mandate was to take care of Native Americans, who were not being served by IHS or, who are urban. But it's essentially, it takes care of people who are indigent, homeless, and who don't have insurance or who are on Medicare, Medicaid. I mean, we take people with all kinds of insurance, but mostly it's patients who are more or less down and out.
In your experience, what type of like mental health issues affect these patients like most commonly?
Okay. So, and I'm only talking about the patient population I see, Lucy, because I don't know what, other doctors see. They may see patients who have more resource, but the primary thing that probably affects all the patients I see is trauma, poverty, and trauma. And then, of course, there's alcohol and substance abuse. I, in particular, that's a piece of a lot of the difficulty that a number of my patients face. But I think my particular group of patients, a lot of it is trauma.
Okay. Do you think living in New Mexico or being part of the New Mexican community has contributed to the way that these patients have had to deal with their trauma or contributed to the trauma itself?
Well, the patients I have who are Native American, I don't know that it matters that they're in New Mexico or if they would come from South Dakota or, different, but there's like ancestral stuff, just like for a Jewish community or, so I think in particular, I see a number of patients who struggle with all kinds of things from having that family story and also, I guess from life on the reservation. And when there's strong community, people do better. But I think, some of those communities have been really fragmented. Or I don't know. I'm hearing from the people who are struggling. So the healthy part of these communities that are functioning and doing well, I am not all that aware of because I see the people who are having, problems. So I think that's a particular population to New Mexico. I think the fact that New Mexico is a poor state contributes, in general to people's difficulties. And I have had a number of patients who are here, with green cards or who are here because their family is here, but, they're not here with the proper documentation. And that certainly contributes to their stress and what's going on for them.
Okay. So how do you think the stigma and misconceptions about immigrants and the Native population kind of like feed into their lack of access and their lack of like resources?
The agency I work for is set up particularly to provide services to Native Americans and people who are down and out and immigrants and so we're one of the resources, but I don't know that there are many. There's mutual aid. There are resources in the community, but we have a long wait list for patients to see doctors and psychiatrists and for the services we have. And sometimes because we're federal, we have some federal grants, we have state grants, sometimes we don't have the resources to give to people. I think, we're a poorer state, so, people have less resource.
That makes a lot of sense in terms of like the way that the whole system is set up. Moving on to different topic, what types of treatment do you most often use when dealing with your patients?
Well, in my role, I'm really circumscribed to sit with people and try to, do an evaluation to see whether an intervention with medication could be helpful for them. We used to provide therapy resources and case management resources. The agency itself provides a dental division. They have a pharmacy. We have a traditional medicine office. We have various things. But what I'm supposed to do is have people come in and, evaluate, diagnose, evaluate whether medication could be a possibly good intervention. In reality, what happens, though, is because there's a dearth of therapists, a lot of times patients come in and I'm providing social contact. The woman I work with, who is supposed to be the administrative person, often isn't put in the position of case management, like trying to find resources for people, because we don't anymore have a specific case manager working with us. But I guess what I'm supposed to do is an evaluation, see if medication is possibly something that could be helpful. And what I see myself doing is being a good listener and providing social contact and a place for people to talk, to have some kind of, feel like someone cares about them. I think is probably the biggest thing I do.
So what criteria do you use to determine whether a patient needs like social contact or therapy versus like medication?
Well, it depends on, okay. So when I'm getting someone's story and doing an evaluation, what I'm looking for is to see where are they getting held up in their life. Like what is it that's providing like an obstacle for functioning. So, somebody with anxiety that has good coping skills, probably the better thing is to have them see a therapist so they can learn, how to, well, if they have good coping skills, they've probably seen a therapist and can settle their nervous system. If the intensity of their symptoms is so much so that they can't use the skills they have, or they don't know the skills, and it's causing them problems in their life that they can't do their usual functioning, then I'm considering whether a medication might or might not be helpful. It's not so much the symptom. It is the symptom, but it's also how are they functioning with that symptom. A lot of my patients, unlike I think usual medicine or medicine where people are thinking, oh, we're going to give you, well, no, it's not usual medicine. I think it's the difference between chronic illness and acute illness. Actually, you have something acute like a cold, you're looking for it to go away. You have pneumonia, you're going to get hopefully antibiotics or whatever it is, and it's going to go away and you're going to come back to your healthy functioning. But a lot of my patients, they have symptoms that are chronic, and the symptoms for a lot of the patients are there. So what I am looking is to see whether medication can help them with the intensity of the symptom so that they can learn coping skills and they can function even though they may or may not be having the symptom. So the symptom would be with less intensity and less frequency. A lot of times what is the trigger for symptoms for my patients are socioeconomic things, like they're homeless, there's no place to live, they don't have enough food, or there are things that medication is not gonna take care of the etiology. So it's about how to help them cope and maintain.
Well, I was doing research for this project and I didn't really come across that mindset, and I like having like the perspective of treating not necessarily the symptoms of the illness, but treating what's like dysfunctioning. And so I think that's like a really good perspective to have, because in the past there were a lot of doctors who were like, no, we're just going to medicate you. So,
well, and people do that.
Yeah.
I mean, and sometimes when it's extreme, you are just looking at the symptom. But I'm an outpatient doctor. Said I think inpatient psychiatry, when you're doing inpatient stuff, it's a bit different, than what I am working with people who, they're either going to agree or not agree to the treatment plan. Like I can, they can decide I'm not going to take that medicine, or they forget to take it, or they get involved with whatever, So even if I'm recommending something, it may or may not be that the patient is going to agree or, to do that, or they come up with their own ways of doing it. Or so it's about the relationship and trying to negotiate and agree, like, what is it that you want to change, or what is it that you want to feel better, or do you think you can, it's not as cut and dry, I think, as in the hospital.
So in your experience and where you work, what does like long-term treatment for chronic or severe like mental illness look like? Are those people mostly regulated to the hospital setting?
No. People can have like somebody with schizophrenia or bipolar or PTSD or any of those, diagnoses. The symptoms for every person looks a little bit different, so it's not like, and the chronicity of it or what the triggers are, or when something exacerbates the symptoms, that's different. What people are vulnerable to and what stresses them is individualized also. So a lot of times, at least in the patient population I see, medication is involved, and it's a matter of monitoring whether or not, first of all, whether the medicine is effective, whether there are side effects, given the stresses and people's triggers, whether something needs to be adjusted. Sometimes there's just a cycle of things. Like sometimes people, for instance, with bipolar disorder, can be affected by the seasons, or sometimes when they're stressed, or if they lose sleep. So it's kind of like helping people know themselves better, so that they know what kinds of situations are stressful, or what kinds of situations trigger them, or somebody like with panic, or anxiety, like what kinds of situations can, if they learn about themselves well, so that they can be preventive, or they can, either know that they're gonna, take medication preventively, or that they shore up their coping skills for those situations, or they have plan B, like if I'm in a crowd and it's too much for me, then I know I'm giving myself permission to leave the store, or so what it means to take care of people with chronic illness is seeing them regularly, monitoring whether the medication is effective or not, if there's any icky side effects to it or not, and whether things need to be adjusted as things go.
Okay, yeah, that makes a lot of sense. More broadly, or like the broader picture of New Mexico, what do you think are like some of the biggest barriers that people face when trying to get access to like mental health resources?
What I hear patients say is that there's no providers. Like, my clinic used to be more comprehensive. COVID came and we lost a lot of therapists. We don't provide therapy services through my teeny little division. And it's hard. They're waitlist for therapists in town. Sometimes I think like UNM serves a similar population to what we serve. But when I have patients that need more, and they have more comprehensive services than our clinic can provide or does provide, and a higher level of care and a higher spectrum of care, but they cannot get in. I mean, the wait lists are like, so I think there's a dearth of resource, like of providers, at least from, and I also know that's just in mental health. When I'm having patients, trying to see other specialties like neurology, where I had a patient come in recently and say her rheumatologist left town and now there is nobody in all of Albuquerque who can see her. And I don't know, is that true or not? I don't know. Maybe there are people, if she had a different insurance, so I don't know. But I think, there aren't enough providers.
Would you count the time period that we are in now as kind of like a setback to the healthcare industry with like the lack of providers in New Mexico since COVID?
Well, I think even before COVID, we had a hard time getting patients in to see other providers. I think it is worse.
At least from what I've heard, a lot of doctors in New Mexico are leaving. So thank you for still being here. Okay, this is kind of going back to what we were talking about earlier about your patient population. How do you think cultural background, language, or traditions influence mental health?
It influences how you understand what's going on for a patient and trying to understand what the patient is describing to you. at our agency, we pay attention to that a lot because of, the services they provide are, I think they do sweat lodge, and they do a lot of Native American, and I don't know how many ceremonies, but we're not so put off by trying to connect to a medicine person, or, and I have some patients who are from Cuba and Mexico, and they have some kind of connection to, Santeria. So, when they're telling me they see visions or they hear things, but it's consonant with how they've grown up in their belief system. So I don't, that makes sense to me. I don't know, just even with mental health itself, the DSM, which is, how the listings of how to diagnose people, based on research, it's like, sometimes I wonder if those diagnostic categories aren't, for profit, to benefit pharmaceuticals. No one fits clearly, well, at least the patients I have are really complicated, and so for broad strokes, no one fits into any category really, and few people fit into these categories in a clear way, but people are more complicated. So I think cultural stuff is vital to understand. I had a patient who came in she was from Afghanistan, speaking Farsi, and we had to have a translator over a translator service, and it was really difficult. And I think because of my background in anthropology and stuff, I try to pay attention to cultural, the ways people say things, and different ways of, that people are because of the societies and the cultures that they've come through. But I just really felt like we were not going to be able to take adequate care of her. We are lucky enough that we have a Spanish-speaking provider now, and that's like a godsend, because my Spanish is okay, but I know that I'm not getting everything, and a lot of times I am using a translator. But when I've offered for people to see our provider who's Spanish speaking, it's a big relief, and I think it is, because people can talk in there and be understood better, and I think that only leads to better care. So I don't know how other agencies do with their sensitivity to different cultural backgrounds, because I only have experience at First Nations. But I think that's definitely something that all providers should keep in mind, that where people are coming from, and what their value systems, and where their cultural background.
Yeah, it's a very in-depth answer, I think, and I just like to follow up on that. And you said you work with patients from the Indigenous community and the Hispanic community, and also from immigrants from other countries. I just was wondering, with these patients, do you ever encounter people who maybe don't want a specific type of treatment? And if so, how do you handle those situations?
Well, even with people who are, not in those categories, I encounter patients all the time who, they will, it's a negotiation about what kind of treatment is going to work for them, or what is going to be acceptable to them. A lot of times patients are coming in looking to get a medication, because I guess in our culture, I think especially in older women I've seen, that taking a pill is going to help you, and it's easy. And you don't have to do therapy. You just give me a pill and I'll feel better.
Yeah.
And so I have that go on too, where I am reluctant to give somebody medication, because I think it's not going to be the be-all and end-all. That a combination of that and therapy would be helpful. So when people from different backgrounds come in and they're using herbal things, for instance, or I try to keep track of what they're using and try to figure out if there's an interaction between that and anything else that we would suggest. But I think by the time people are coming in to our clinic to see me, they really are at sort of in a state of need or discomfort that, and a lot of people have tried their home remedies or whatever it is that their families do, and they're still not feeling well, and that's why they're coming in. So they're a little bit more open to doing an allopathic kind of intervention.
I just think there are a lot of different forms of medicine that kind of interplay in New Mexico, and seeing that you acknowledge that and like help your patients as like an additive, or instead of just forcing something upon them, is like
no. I really, even though part of my job is giving medication, I really don't like doing that. I'd rather have people learn skills if they can, and I don't have a problem with people using acupuncture, homeopathy, herbal stuff, as long as I'm kind of aware of what they're doing, because what works for one person doesn't mean it's gonna work for everybody. Like hypnosis. I feel like whatever works, as long as it's not interacting in a bad way, and as long as the providers are ethical, I don't have a problem with that. There might be other people who really don't believe in those things. Ayurveda, that's fine. I go for it.
Yes. Okay, so kind of more focused on you. What challenges do you think mental health providers face in New Mexico?
Well, I think the job is really, really hard, and you hear people's stories, and that's really, in my particular experience, I feel like I've seen a lot of the supports erode for providers, meaning that there used to be staff meetings, there used to be things that helped buoy the providers, so that when you're doing the hard work, you feel supported yourself. And I think as medicine in general, not just mental health, has become more business-like versus, I'm old, and I guess I have been practicing for a while, 35 years. When I started, the conversation in medicine was all about quality of care and taking care of patients. And at some point along the line, the conversation, at least, in some of these agencies, was not so much, not that they don't want you to provide quality care, but the emphasis became on productivity and billable hours, which is like, when I first encountered that, I thought, well, that's like business language. And certainly the places I've worked have been community mental health centers or nonprofits. They have to be able to either have grants or funds or enough money being paid to them for them to exist so they can provide service. I get it. But I think that medicine is really messed up. I mean, it's 15-minute appointments. I don't do that because I'm old and I don't think I can work that fast. And I don't but I don't know how the family docs do that, 15-minute appointments. I mean, and people in medicine are being trained differently now than I was trained. I mean, I know they're more problem focused, and when I trained, we were more comprehensive focused. And so I think, that changes things. So I think in mental health, there's not enough support. I think people get burnt out. But I think medicine in general, that providers are being burnt out, and that shift from quality of care and doctor-patient relationship being the focus to productivity and billable hours is like been the death of the kind of medicine I thought I was going into, when I first started.
Do you have any policy changes that you believe would help kind of remedy this situation?
Yes, well, I think that we should have universal health care. I think that if we did, and even that, I don't know, there probably would be problems with that too, but get rid of the insurance, let people have health care, that would help.
Yeah, I agree.
you know?
There are so many people that I know who can't see or be treated the way that they need to be treated because, like, their insurance isn't taken by that provider, or they are on a 6-month wait list, or things like that, where it's just like access to care is supposed to be speedy and efficient, but it really is not.
No, it's not. So there's, like, you know, the problem of, are there providers available? Like, is the resource available? You know, even if they take your insurance, is it like a year wait to see, a 6-month wait to see somebody? Yeah. And then, you know, who takes your insurance? You know, and a lot of patients I see, you know, providers who might be able to see them more quickly don't take their insurance and won't see them. And equally, even, you know, writing for medications, I have to go through a lot of hoops sometimes for these prior approvals for, like, you know, insurance companies saying, no, this patient can't have this medicine they've been taking for 5 years. I'm like, well, they're stable on it. Like, what? You know, you have to do all this paperwork to get them the medicine they've been taking. Or you switch insurance company and you have to see a different provider, and then their formulary doesn't cover the medicine that the person has been stable on. I mean, it's really ridiculous because they want to save money. So, I don't know, universal health care, at least everybody wouldn't get bankrupted by getting, and then, you know, people don't see providers because they can't afford it, or if they go to the hospital, then they can't pay their rent, or you know, right. I think the wait times, it's a two-pronged thing. I think in New Mexico, you know, there's not as much resource in terms of providers, but also I think the whole insurance thing also limits people and is crazy. So I think we should have universal health care, and whatever problems come up with that, we work it out.
Yes. What would you recommend someone to do who is struggling, like, to get help here?
Well, there's that 988 line that can be called, and a crisis line to talk to people. Often they will be able to direct you to what resource is available. And, you know, I would really encourage people that they're having a hard time to not, you know, to talk to whoever their support system is. You know, if it's really bad, show up at an ER, you know, a crisis center. I mean, get help. You know, I think people feel, sometimes when they feel so isolated and lonely, that's where it gets dangerous.
For people not experiencing mental illness in New Mexico, what do you wish that they would, like, understand more about?
One of the old myths that is just an American kind of thing is, well, just like, if you, what is that saying? Maybe you know it, Lucy, like, pull up your bootstraps? Or
pull yourself up by your bootstraps.
You know? And I think, you know, maybe these days that's been dismantled a little bit, but, you know, I think some people think that if someone is depressed or they're struggling, it's, you know, they should pull themselves up by the bootstraps. And I think, you know, psychiatry or mental health things, in some ways we don't really understand. I mean, we know a lot and we don't know a lot, but I don't think it's ever that someone's not pulling them. Yeah, like, that is a myth, that if you work hard enough, or if you just got over it or whatever, you know, I think that kind of mentality, or making sense of other people, is faulty. I also think that, you know, people get scared of some of the homeless people they see, especially people who are doing drugs, and I think that it can be really scary. And I think a lot of those the people who are struggling, they are struggling. It's not because they didn't work hard or whatever. I think that's where, when we started off the conversation, saying, you know, my view is that I think a primary problem is trauma. It's all kinds of, and poverty, and families not having support to begin with. So that lead to all kinds of problems. So it's not a fault of the individual, I guess. I think it's more of a societal fault that we don't take care of people in our community, and we don't see people as maybe different and valuable or worthy. Like, you know, what did there's all kinds of sayings, like, you know, is you're doing better, then I'm doing better, opposed to, oh, it's all about me, you know, like, and who cares about you? You know, it's a different mentality. But So I don't know what I would say. Just that I think, that is a myth. Pull yourself up by the bootstraps, and if you're not doing okay, well, you didn't work hard enough. That's a bunch of crap.